Hello, my name is Dr. Alison Duncan. I'm a structural interventional imager from the Royal Brompton Hospital in London, United Kingdom. TMVR imaging is very complicated because the mitral valve is not the aortic valve. The aortic valve is a valve simply at the end of a tube, whereas a mitral valve is a very complicated dynamic structure. It's saddle-shaped. It's associated with the aortomitral curtain. It can be related to the left ventricular size, the left ventricular outflow tract, and the fact that there can be calcification around the mitral valve annulus or not. So it's not at all a tubular structure with straightforward imaging. It's much more complicated than that. So there's several different TMVR devices, and the Intrepid system is one of them. The Intrepid system is a transfemoral transeptal device, which is a circular device. So in the first instance, we are less concerned about the orientation of the device once it's in the mitral valve annulus. It can go in any orientation because it's a circular device. And equally, because it uses radial force against the mitral valve annulus, we don't have to worry too much about the subvalvular apparatus docking system type procedures that are available in other forms of TMVR. But we do need to think about left atrial size, the anatomy of the interatrial septum, the subvalvular apparatus insofar as the distance of the papillary muscles. That's just outside of the mitral valve itself. For imaging the mitral valve itself, we would think about using multimodality imaging. So echocardiography, transthoracic and TOE, and CT scan, with a view to try to figure out three things. The mitral valve anatomy, annular size itself, to make sure that we've got a valve that's big enough to fit in the annulus, and that when we put that valve in, that it's not going to obstruct the left ventricle or the left ventricular outflow tract. So all of the pre-procedural imaging will help us to come to that decision, but the two main imaging modalities will be transesophageal echocardiography and multi-slice CT imaging. Well, this is a transfemoral transeptal procedure, so we need to have good imaging of the interatrial septum to start with, and a good enough interatrial transeptal puncture site to be able to manipulate the guide catheter into the mitral valve annulus itself. We, as I mentioned already, because it's a circular valve, we don't have to worry so much about clocking or orientating the valve in terms of its clockaging within the mitral valve annulus, but we need to make sure that we've got it at the right level of the mitral valve annulus so that the retaining elements are pushing out into the mitral valve annulus and not too high, not too low. To do that, we used to use a biplane transesophageal echo imaging, but now with the advent of multiplanar reformatting imaging, it's much easier to look at the bicondylar picture at the same time as a three-chamber view with an en-face 3D imaging, so that we can make sure that we are at the right depth, at the right angulation, the right orientation of the annulus, and we image the annulus and bring the device to the annulus rather than measuring, imaging the device itself. So the key is multiplanar reformatting, imaging of the mitral valve anatomy itself, and then the interventional cardiologist brings the device to us. Well, sometimes we do have issues if the left atrium is small, and that's obviously not usually the case if somebody's got severe mitral regurgitation. Normally they've got large left atriums, but in some cases with mitral annular calcification, where there's mixed mitral valve disease and possibly predominant mitral stenosis, the left atrium may not be so big, and therefore it is sometimes a little bit tricky to orientate and guide the guide sheath down onto the mitral valve annulus itself. And at that same time, the TOE probe can be, well, the guide sheath can get in the way of the imaging from the TOE probe, and so it can create some acoustic shadowing over the mitral valve annulus itself, and therefore it can make the imaging tricky, which again, where multiplanar reformatting imaging comes in handy, because at least in some of the views you'll be able to see where we're going. The other thing is, of course, is when the valve is being deployed, is to try and follow that in real time. And again, that can be sometimes a little bit tricky with TOE positioning, to make sure that you can see the device being fully expanded without acoustic shadowing that occurs naturally with the guide sheath position. Well, first of all, it's a fantastic system. It's a really, really nice way to eliminate mitral regurgitation in a very consistently effective and durable fashion. So I would encourage teams who have patients who have got significant mitral valve disease, who are not suitable for surgical mitral valve intervention or transcatheter edge-to-edge repair, to screen their patients for TMVR with the Intrepid device. The main anatomical reasons for screen failing are, as they always have been with TMVR devices, is either the annulus is too large or too small, or the ventricle is a little bit on the small side, and or the LVOT, the left ventricular outflow tract, is either intrinsically small, or when the valve is positioned into the mitral valve annulus, it can cause left ventricular outflow tract obstruction. So if you think your patient could be anatomically suitable for TMVR and they're not a surgical or repair candidate, please do perform a comprehensive transesophageal echo imaging. You will be able to obtain the annular size. You will be able to get a good idea of left ventricular outflow potential issues, small aorta mitral angles, narrow left ventricular outflow tract diameters, very long and unsupported anterior mitral valve leaflet. If your patient doesn't have any of those, please do send them for CT scan, and we can corroborate those findings and see if, when we superimpose an Intrepid device into that patient's mitral valve annulus, whether they would be a good candidate or not for the system. And if they are, it's a very straightforward procedure, relatively, in experienced centres, and the patients who have successful procedures, which are the vast majority, really do feel much, much better afterwards, with effectively only a puncture in the groin rather than a surgical access. So definitely, if you think your patient might benefit, please do screen them.